Very well. Well, sorry I didn't change. I still talking here. So we're going to be discussing a little bit about skin. Not a lot to really influence in your practice, except for 2-3 things that I believe that they're imperative for you to know. Learn the layers you already know, so epidermis, dermis, and hypodermis, what structures are within each level. Review a little bit about burns and wounds, because here I think is an important moment to review the pathology of those situations or those conditions as a burn, first, second, and having a second A, second B, and a third degree, and even 4th degree burn. Same with wounds, first, stage 1, 2, 3, 4. And what are the features and characteristics to define each one as classifications? Some skin facts: it protects, can be traumatized. The important thing that once it's traumatized, the nice thing is typically it will form new skin, and because the type of cells most likely will be a normal type of skin. The only ones that will not be is where there's a deeper injury, more scar tissue, and either thermal, deep thermal or chemical, or even burned by gasoline, for example, will leave those scars, incisions, will leave some scar tissue there, but it's covered nicely. Acute injury differs from chronic or repeated injury, and normally will have normal bacteria over the skin. It reacts to foreign substances in a way, and it's also affected by some diseases as metabolic, immune, systemic, and either may change of color in some way by hypopigmentation. I just mentioned last class about the injection of steroidal in the skin and producing the skin atrophy, or hyperpigmentation that can be because of some metabolic conditions. We spoke about Addison's, the changes of color to a little bit more darker color, or if you have exposure to sun, melanocytes will increase its activity by certain factors, and that will bring a tan, a darker color. And also they have a limited response to injury, like you can imagine. So we're going to review some of these major diseases. Some lesions, you can read them here, but as macule patch, papule, nodule, and tumor, what it means by the characteristics and size of it. Same with a vesicle, bulla, pustule, and ulcer, same things. What it includes as a term and why you're going to call it that way. Review it on your time cell, very easy, and go slowly with each one. Crust, scale, squames, excoriation, fissure. What happens and what instances you might have it as an example. Because here, this is where you're going to resume everything. You're going to do an analysis of each one. Why are you going to call it a macule, a papule, a vesicle, pustule, what it includes in each one to be called that way. Some are easier to remember than other, but think about it. Congenital disorders, probably in your case, you probably can think about some of them as birthmarks or nevus, or some of your freckles that might be important to know or not. Ichthyosis congenita, we'll touch about it a little, talk about it a little bit. Albinism really is no big deal or problem, except if you want to treat them in the outdoors. Epidermolysis bullosa is something that has to do either with something that is born or something that can be related with some antibiotics. An external injury, like we just mentioned, what the skin will protect you, or what is the skin for. Mechanical trauma, thermal injury from burns or cold, and including burns, anything, electrical or radiation injury. So, like I said, go over the burns grading that we went over in anatomy. So you're going to have a first degree that just says erythema swelling. It's painful, but it's transitory, reversible. The second degree is typically A and B, or superficial and deep. And in second degree superficial and deep, in both you're going to have blisters. The thing is, with a second degree deep, symptoms might be not as constant, but second degree superficial is very painful. That's when the second degree, those blisters will eventually dry and the skin falls. The third degree and fourth degree really have to do with the depth of this burn, and think about just reaching a certain level as fascia or aponeurosis of the muscle, or going deeper and expose bone and affect bone in some way. But it's a full thickness once you reach that third degree and fourth degree. The rules of nines that we talked about, remember that we're going to be looking at when a burn surface is applied, 18% will be for the trunk and anterior and posterior. Rule of nines means that you're going to have for each leg 9, considering 9 anterior, 9 posterior. Your upper extremity will be 9, but it's going to be divided anterior 4.5 and posterior 4.5. So if you add them, you're going to have 9 for your left, 9 for your right. For your lower extremities, they're going to be 4, because you're going to have 2 anterior, 2 posterior. That's 6. You're going to have 18 anterior, 18 posterior, which is basically 4 more. So you already have 6, so that's 10. And you're going to have another 9 for 4.5 your head anterior, 4.5 your head posterior. That's 11 times 9. That's 99. 1% is genitalia. Frostbite is one type of condition that will occur under certain circumstances of very low temperature. Blood flow doesn't reach those tissues because of a mechanical, physical activation of your body, and not enough blood supply goes and reaches those distant areas, so they eventually go into necrosis and they're lost. So cold injury by immersion foot, what it's called. So you can imagine any going into some cold weather, not necessarily going into water, but just by walking, but that happens. So in sunlight injury as thermal injury, the acute and chronic exposure, they're going to have different situations. In the acute exposure, you're just going to have hyperemia, probably some vesicle formation as blisters. When it's chronic exposure, and this is something with the tanning type of process that a lot of people go to those salons to get tan, the dermal tissue gets some sort of degeneration, and this is something chronic, that the atrophy of the epidermis is going to follow, and hyperpigmentation is going to be present. Chances for tumor formation because of activity is going to be increased. Some infections that you might have as primary, secondary, systemic, I'm really not going to go into detail of them. Just remember that all of them can be considered caused by strep or staph. Like I said, we just talked about the skin having bacteria. Staph bacteria, Staphylococcus epidermidis, is the one that is there, but it can be by any other bacteria. Impetigo is typically by strep. Folliculitis, furuncle, and carbuncle is typically by staph. MRSA is a big thing in this moment. So again, it's a schematic representation of what impetigo means, what folliculitis, so a hair follicle is infected. Furuncle is just the size that's increased and it reaches a deeper level. And carbuncle is more of an abscess that has spread throughout. Impetigo by strep is the most common thing. Remember that strep, even from the skin or from the strep throat, can cause eventually in later stages, not taken care of properly, those toxins of strep can go into rheumatic fever. Now, this type is commonly by type A, the Streptococcus viridans, and Streptococcus viridans is not the same aggressive as the other type of strep for throat. Fungal infection typically is going to live in dead tissues. Any common sites that you might think about, and they have specific names. Tinea capitis for the head, tinea corporis for the body, tinea cruris for the groin. Those are specific names for fungus that are active over the skin. In some viral skin infection, the one that are typically caused in infancy or childhood as measles, chickenpox, they're distinctive and very easy to differentiate from other type of conditions, and this typically makes the diagnosis as what type of skin reactions you have. Obviously, talking about herpes and HPV, you're going to have vesicles, as chickenpox is part of the herpes viral family, and HPV, the human papillomavirus, is going to be the formation of warts. Warts are not painful. All the other, probably measles also is not that painful, but it causes a lot of itch. Same with chickenpox. It's a lot of scratching. In some other conditions, bites by insects like fleas, mosquitoes, bed bugs, lice, are just a reminder that you might have some infestation in your clinic by some patients, so be careful. Scabies is another by one of the specific parasites, and these characteristics, they burrow some holes through or tunnels into the epidermis. Between the fingers, toes are the most common sites, and even into your volar aspect of your forearm is very typical to see them into the antecubital area. Another topic here is acne, a common situation that it's an infection within one of the sebaceous glands, one of the glands that will secrete either some sebum, some fatty type of product, and you can feel your skin sometimes being oily. Well, those are the sebaceous type of gland that, because there's a plug in the way out, they start just increasing in volume by formation, and the same bacteria that's in your skin gets in and produces an infection of that area, can break through and go into another field, or probably they can be controlled, or you can just flush them out, whatever your technique is. But another theory behind this is stress, hormonals that will tend to lead to form this type of conditions. Pimple, acne is well suggested, recommended. Do not touch it. Just wash your face. Make the level of oil locally decrease. It has to do with stress, with some foods like peanuts, a lot of starchy foods, try not to eat them. Avocado has a strong influence with the presence of acne in certain age, and typically this is hormonal type. If you recall, when you were about to become a teenager, probably from 12, 13 to 14, you probably had a little bit more of this presence. And again, this has to do with a break between some of the estrogens and sexual hormones that you're going through that period of time. Eczema or dermatitis is just forms of some inflammatory skin disease. Again, you can go through just edema or some erythema or some specific changes as papules, macules, or vesicles. Typically, an eczema or dermatitis goes with an itching, pruritus type of feeling or sensation. And you can have something that's either endogenous of unknown reason or exogenous from infection or irritants locally. Seborrheic dermatitis or dandruff. Dandruff obviously is more related where there's hair, but you could have a presence of seborrheic dermatitis anywhere in your body, but this is the most typical places. Shampoos and use of the steroidal medications typically would call it. Psoriasis is one of the things that, as a therapist, you have two folds to be careful of and be aware of, or three probably. One, the most important thing is your patient, your client that has psoriasis. The first thing, you have to be compassionate with that person, because this is not an infection. It's something that is not going to be spread out. But for the person that has it, somebody that tries to reach to do massage, to do some treatment, probably will hesitate, have a second thought, and that should not be done. Psoriasis, nothing to do with it. Probably not nice, but you can cover it. You can do something and basically saying, I want to take care of you, not saying I don't want you to get my things contaminated or do a special thing for that matter. So that's the most important thing. Second is that they have flare-ups. So sometimes they can be controlled and sometimes they're not. And when they're not, that's when the patient is a little bit more into anxiety, anguish, mad, and they have changes in mood, and you'll see them. And the third fold, and the most important thing for you, clinically speaking, is that they can also be affected into their joints. So they have arthritis caused by psoriasis. So psoriatic arthritis is important for you to know. And now there are more and more medications that you've heard of on TV ads about biologicals. So those biologicals are also termed inflammatory modulators. They control inflammation. So they're different, these biological products, they're different from the anti-inflammatory medications, even steroidals. But the steroidals or corticosteroids and the non-steroidal anti-inflammatory medication that you know, they will control somewhere or somehow pain, mostly a little bit about the inflammatory condition once it's there, but it's not controlling the disease. What you really want to do is control the disease. And even for these people that talk about psoriasis, it's not to remove and clear the skin in 4-6 weeks or 4-6 months. It's nice, but if the clearing goes along with not the cure, but the control of the disease. But some can be extremely problematic for you. As you can see here, there's a big patch, scales that are there. Stress is considered to be a big factor here, but there has to be another reason for this. So in terms of neoplasms, you're going to have from those cells as epithelial cells, the pigmentary cells, connective tissue, and some immigrant cells. Epithelial cells, the seborrheic keratosis or senile wart, is the most common epithelial skin tumor. This is benign. Two things that you're going to see most in some patients, not you're going to treat them, of course, but you're going to see them probably happening if they are outdoors a lot and not covering themselves properly. People that go 40, 30 miles in bicycle twice a week and no protection. So they can get either basal cell carcinoma, BC, or squamous cell carcinoma. The basal cell carcinoma is most common than the squamous cell, but the squamous cell has worse prognosis, and typically you could have seen or known that there was a situation called actinic keratosis, and this is a carcinoma in situ for the squamous. For basal cell, and the other thing is, again, related with sun exposure, but the basal cell has not a law, as a rule, but it's something that is common. From the nose up, you're going to have basal cell. From the nose down, you'll have a squamous cell, and that's something that is just, you know, a statistic, and there's observation. Basal cell above the nose, and it has a very distinct feature of how they look: round, well delineated, not ulcerated, but it can be raised in a way, as it's here, shows a raised margin, a little bit of ulcer there, basal cell, but that's not the typical site. The squamous cell, on the other hand, nose down, is more of an infiltrating, and is going to be, or have more of a plaque into an ulcer, typically, and bleeds quite sometimes. So how to tell skin cancer? If it's a persistent, non-healing ulcer, think about that. Melanoma, or something like I said, freckle, that you could have in your palm, or in your sole of your foot, not the sole inside of you, but the sole of your foot. You could have a non-healing ulcer. Think about that, a malignancy, that it's not healing. If there's an ulcer or some nodulation, but typically it's irregular shape. If it's very perfectly shaped, go more with a benign condition. If it's an irregular shape or doesn't have good margins, think about a malignancy. It's friable, so it can easily bleed. Again, has several colors, from very red to a little bit of pink to black or bluish, green. Think about multicolored. It's more of a skin cancer. And again, friable means that it's going to be easy to bleed. There are some indurated margins of that ulcer or tissue around it. So the ulcer is one thing. You have that ulcer or nodule of irregular shape, but it's surrounded by this indurated margin. And the skin surrounding that, that indurated skin surrounded by atrophic and keratotic skin. So typically of sunlight injury. So these are the pigmented or pigmentation on the skin lesion. Like I said, a freckle, what it means, lentigo, lentigo, the types that you can have. Those are pigmented, but they will not necessarily respond to sun. Moles or nevus, you've seen that. Nevus is just a mole. It's one of the situations that can be congenital or can be acquired. And this is just a pigmentation in one single solitary area. And obviously finally the malignant melanoma, which is a malignant tumor of the melanocytes. And where do you have it? Any place in your body, but is more likely to be in the skin that is exposed to sun. In other areas that you might have a lot of friction and the skin is constantly suffering changes, those sites where there's a lot of friction, rubbing and changing of the skin also will cause some sort of cancer. So as a little while ago we saw some type of lesions on the skin, these are the pigmented lesions of the skin, as freckle, lentigo or lentigo, nevus, the mole. You're talking about a malignant melanoma. So something that is very well defined, homogeneous type of coloring. You can think about this being more of a benign lesion than this one that has spread out, has some changes in coloration from red to more purple to probably black. That's going to be more of a malignancy presentation. So malignant melanomas, this lentigo maligna, the malignant freckle, is a flat macula seen in older people. The superficial spreading melanoma is just an irregular macule of flat area. You can have a nodular melanoma, and this, like I said a little while ago, the acro-lentiginous type of lesions, palms and soles of your foot. So the ABCD for malignant melanoma, there's some asymmetry of that pigmented lesion. The borders, borders are irregular. Color from variation from dark black to dark brown to red. And diameter, this is important. So if any lesion exceeds 6 millimeters in diameter, think about a malignant melanoma. Kaposi sarcoma has to do with HIV, with AIDS, and this is a very specific type of cancer that the skin will develop in those immunocompromised patients as having HIV and or AIDS. Philadelphia was a movie that Tom Hanks did, and some of the lesions that you might see there during the movie, obviously not from him, but resemble Kaposi sarcoma, and that's how they figured out. At least one of the lawyers at the firm said that person might have disease, and even though they didn't know it was Kaposi sarcoma, but that's what it was. Now for the nails, there are some specific terms that you have to know and learn, but probably the first thing is to know the parts of the distant part of the finger or toe. So you're going to have the nail root, the cuticle, you're going to have the lunula, which is a half moon, the nail body, you're going to have a free edge too, the nail bed, and the nail matrix. So the nail root and the matrix are in the same position, and this is where the nail grows. So you can cut it all the way here, and if you have the nail root, you'll grow a matrix, and eventually that nail will grow again. Terms of diseases. Onychogryphosis is when it has a shape, a wrong shape. Koilonychia. Onychomycosis, this is the fungal infection of a toe, of a nail. And the paronychia is the infection of the nail bed. Paronychia, infection of the nail bed. Causes, any bacteria that you think could be a simple one, typically it is, Streptococcus viridans or the Staphylococcus epidermidis, which are two basic bacteria that are in your, within your skin, but for some reason you had a trimming of the nail done with some contaminated scissors, or you poked something trying to remove dirt or whatever you have there, and it injures that nail bed, that gets infected, that's called paronychia. Hair diseases. Hirsutism is just increasing hair in your body. Alopecia is the other way around. You lack hair, and alopecia is typically coming from hormonal changes, familiar changes. Men will have alopecia more than females, but females are also having that sort of condition, or what is called alopecia areata. Alopecia areata means that there's one spot in your head typically that lacks hair, or you can have your beard that doesn't have one spot of hair. Tinea capitis is not the infection, but it's it's the fungal infection of, like I said, the tinea, which is a fungus, and the region of your body, in this case, the head, that's where you have this fungal infection. Trichotillomania is the neurosis or a type of anxiety that you pull your hair to release that pain or that mental process. So that'll be the end of the skin. Probably the only thing that I would add to this is to think about in skin conditions when you have a patient or a client that's going to go for treatment, that patient might have some specific allergies. So think about those allergies, that because whatever you have as covers for your sheets or something that you have for your massage tables. Could be paper, that's fine, but if you happen to have linen, make sure that if you send them elsewhere for cleaning, laundry, make sure that they're using appropriate soaps or treatments so patients won't suffer the chances of that reaction as an allergic reaction. And the other thing is that if the patient happens to have some skin conditions, protect yourself first. Wear gloves, tell the patient what's going on. If the patient had a surgery and probably might be some sort of local infection, protect yourself, protect the patient, call the doctor, make sure that everybody's on the same page. Make sure that there's no cross-contamination between one patient to another by you taking care of good washing your hands in a professional way, and always change linen or sheets if it's necessary for each of the patients, even though the last one didn't do much thing, but might have had some clinical conditions. Other than that, think about any things that you're going to apply to the patient, like gels or something for your ultrasound, some creams or anti-inflammatory medication, locally topical, to relieve pain or something. These patients might be allergic to the lidocaine or something that is included in that. Menthol, alkaline-4, salicylate are the typical ingredients or substances in a cream or a gel that you're going to find, and those might be irritant to the patients. So think about both ways. You protect yourself, protect your family, protect your other clients and patients, and protect that patient in particular. Thank you so much.